So thank you again, everyone, for coming. We will be recording the session so we can provide you with a copy after. Like I said at the start, we're going to run through the slides. Deanna is going to run through the slides, and then at the end we will have an opportunity for questions. So at this time, we'd ask for you to *1 to mute your line, just so that we have optimal audio for that recording. And Deanna, welcome. Take it away.
Yeah, I can start.
Please.
So good morning. I'm Deanna Telner. I'm a family physician at the community-based academic teaching site, Southeast Toronto Family Health Team. I was co-lead on the development of the Preconception Health Care Tool. Today we are going to discuss how to integrate preconception health care with the use of this EMR form into our regular daily practice. So the objectives of this session are to describe evidence-based recommendations for preconception health interventions, discuss how you can implement it into your daily practice, and present the Center for Effective Practice Preconception Health Care EMR form, and talk about how you use that in your daily work. And then at the end, we'll take some open questions. So just to set the stage, preconception health care refers to the health of all individuals of reproductive age, regardless of identity, gender expression, or sexual orientation. We know from the evidence that good health starts before conception. That is, healthy individuals have a much better chance of having babies who enjoy good health throughout their lives. Preconception health focuses on actions to promote healthy lifestyles, reduce risks, and increase readiness for pregnancy. This includes both the period before pregnancy, known as preconception, and the period between pregnancies, known as the interconception period. These actions also should include the individual at community levels and at population levels. The Preconception Health Care Tool was developed to support primary care providers like yourself in screening, counseling, and treating all individuals of reproductive age. The tool was developed to support the recommendations in the No Time to Wait, the Healthy Kids Strategy for the Ministry of Health and Long-Term Care, and is designed to be used opportunistically over a series of visits. You don't need to complete the entire form in one visit. It's designed to identify potential physical, genetic, psychosocial, and environmental risk factors for adverse pregnancy outcomes. It's also designed to help the provider encourage their patients to develop a reproductive life plan, and if they are wanting to get pregnant, to optimize their preconception health and identify those areas that might affect conception, pregnancy, and infant outcomes. So how do we develop this tool? There was a working group of myself, a nurse practitioner, Rebecca Barrett, and the Center for Effective Practice staff who worked to develop this tool. A comprehensive literature search and environmental scans were conducted. The clinical evidence was reviewed and appraised, and then the tool was drafted, tested with primary care providers in different settings, and refined based on their feedback. We also took feedback from end users and organizations with an expertise in maternal and infant care, and providers who practice comprehensive family medicine. This past fall, we actually updated the tool as well. There was a review of more recent evidence, and additional user feedback was incorporated. Just to list a couple of things that were new is that we added counseling around Zika virus and cannabis use in practice. So how do you implement this in primary care? We realize that there are barriers, such as short appointment times, competing priorities that patients have with acute illness or a current problem, and a lack of reminders to trigger us to actually ask these questions. And also, there's no direct billing code for the service that we would provide. In terms of preconception opportunities for care, this should happen opportunistically. Although there might be some patients that come in the office to specifically discuss this, we know that most patients do not. And it's up to us as primary care providers to start this discussion and review patient knowledge and risks at times when they come to see us for a completely different reason. All patients can easily be asked if they are thinking of getting pregnant in the next year or so. When a patient comes in for a periodic health exam, this is an excellent time to review preconception health in more detail. Other potential opportunities can be when a woman comes in for birth control renewal or other medication renewal, for an STI check, or after the birth of a child. By identifying those individuals that are thinking of getting pregnant, it allows you to educate them on lifestyle choices. There are many examples of this, but some to include are folic acid supplementation and nutrition, including ensuring they have adequate calcium intake and omega-3 fatty acids, the elimination of tobacco and alcohol, and the elimination of other substances, exploring which prescription and over-the-counter medication they are taking, and counseling on these risks, and sometimes substituting a different medication that may be safer in pregnancy, and avoiding environmental toxins. As well, it's important to discuss your patient's genetic background and to screen for any genetic risks before conception. Other health, hypertension, epilepsy, and diabetes can be discussed with your patient. If you help them to optimize control of their condition and consider changing medications or discontinuing some that might be unsafe if they were to become pregnant. As well, screening for mental health concerns, psychosocial stressors, or other factors that may impact their well-being during pregnancy. So now let's look at the EMR form. It begins with the question, ask all individuals of reproductive age, would you like to have a child in the next year? And then you select the response that matches your patient. Regardless of how they answer, you should encourage all of them to make a reproductive life plan. You can link to one directly in this form. Like the paper version of the tool, hyperlinks to resources for both providers and patients have been integrated into this form. If your patient says yes, then the form expands and shows various categories. So you look at all these categories, and based on the primary reason for your patient, you might want to work through some of the sections for the form. For example, if they have made an appointment to discuss their asthma, you can select the chronic medication conditions and take a look through that. So I'm just going to have you take a look at the screen just to see some of the chronic medical conditions that pop up when you link and when you click that link. If you look at the next slide, which we'll just pull up now, this has to do with infectious disease. This provides the infectious disease that are important to screen for if a person is considered becoming pregnant. The form also provides those infectious diseases that providers may want to consider following and counseling as needed, as well as infectious diseases that should be managed prior to getting pregnant. So take another minute and just look through some of the options for counseling along the infectious disease category. Another aspect is the family and genetic history. It's important to remember to look at family history and consider ethnicity-based screening. So you can briefly go through and ask if anyone in their three-generation family has history of any of these conditions, and that would guide potentially further referral to genetic counseling, or sometimes you even need to get a more detailed family history if some of this may be positive. Other sections of the EMR form include nutrition, and we can take a look at that next slide. Here are some of the recommendations for folic acid, for calcium, for caffeine, and for vitamin D. And also see if there's any issues regarding access to food, nutrition, or iron-deficient anemia if they are at risk. So this form is quite comprehensive. There are many subsections that you can click on and open. But the nice part of this is after you've done everything, you can click Finish, and it collapses into one nice clinic note that summarizes everything. So although the form is quite long, you can target what is specific to your patient, write the specifics that you have discussed in the encounter, and then collapse the form to get a nice clinic note. So now we're just going to go through a case. This is just a case that could be in your practice, and we'll discuss briefly the case and some examples of preconception issues that could be discussed. So Jen is a 32-year-old nulliparous woman who comes to see you for renewal of her migraine medication. She has been having more frequent migraines, which she attributes to stress. Her common-law partner of 6 years recently lost his job and has been feeling quite depressed about this. This has also caused them to have some disagreement about their finances. On further questioning, when you ask about her reproductive life plan, Jen states that they were thinking of starting a family soon, but now they don't know if the timing is right. Jen has hypothyroidism, which is treated with thyroxine. She has had genital herpes in the past, but no recent outbreaks. She is currently on Micronor for birth control since she cannot take estrogen-containing pills due to her migraines. She is also vegetarian. She has been on various SSRIs in the past for anxiety. Her common-law partner, Steve, is also your patient. He smokes cigarettes and uses cannabis daily. So this case highlights many aspects of preconception care that should be addressed. Some issues would be appropriate to address at the current visit, while others might be discussed in more detail at subsequent visits. A few examples of preconception issues from this case that could be discussed would be addressing the stress and anxiety triggered by Steve losing his job and the impact that this is having on the relationship and the financial situation, including the timing of pregnancy. In this situation, it might be helpful to meet with Jen and Steve together to discuss this, and then also meet with them individually to further manage anxiety or depression and consider referral to a social worker for support. You might want to recommend that Jen start taking folic acid now so that her levels would be adequate when she starts to try to conceive. As we mentioned that Jen has hypothyroidism, it would be important to ensure that her thyroid level is controlled and also inform her that she will need to increase the dose of her medication as soon as she finds out she is pregnant. You'd also want to review her medication options for migraine treatment, both chronically and acutely, to ensure that this would be safe if she got pregnant. I mentioned that she was a vegetarian, so you might want to review her diet or refer her to a dietitian to ensure she is getting enough calcium and iron and other supplements. It mentioned that her partner is smoking and also using cannabis, so discussing with him this effect on fertility and on the fetus during pregnancy would be important, and also screening for any alcohol use and abuse. Subsequent visits could also review immunizations to make sure that both Jen and Steve are up to date and taking a detailed family history to see if there are any specific screening that is indicated prior to conception. So that's just an example of all the opportunities to integrate preconception care in a patient who is coming in for a different reason to your practice. At this time, I'd like to open it up for any questions.
So feel free to star 1 to unmute yourself, and if you have any questions, we welcome them.
I have one question.
Hi.
Hi, it's Richard. You were mentioning screening for HIV even in this pre-conception visit, and of course we do that when we, it's a part of our prenatal blood work. I just find that interesting that there is benefit to, there's always benefit to screening HIV, but why specifically that one? Or
I think the thought is for all these preventing and promoting section, these are things just to consider. So this would be for a patient that was high risk that you felt would benefit from being on treatment before she was pregnant. So the same way we wouldn't screen everyone for toxoplasmosis or Hep B, et cetera. But if they're high risk, you want to make sure they're controlled before. So it's just things to consider, but you don't not to screen everybody.
Okay. Do you want to do a question, Stella? No. Is this is compatible with the Telus EMR?
Yes. Yeah. So I have this. We have PS, and then that's what we use.
Yeah. Sorry, PS Suite, Mac Medical. Oh, it's had so many names over the years.
Yeah.
But it's that same one.
Exactly.
And this would not be would this be considered a antenatal preventative assessment? So we can bill these P005s, which is an antenatal preventative assessment. Would that?
I don't think, I see that more as the first page of the prenatal record. I usually would bill this as a K013, a counseling.
Okay. Yeah. Okay.
And then obviously if you identified anything, if you brought them back, I mean, if it was mental health, you could change it to K005, et cetera.
Okay.
That was what I was going to next ask. In your practice, what do you build these counseling sessions as?
Well, any counseling would be K013, but I must admit I don't really do this prenatally. I guess that's why you're doing this, and you're promoting this.
Yeah, and I think the first time you do this, to be honest, it can be a bit overwhelming, but you have to just keep in mind you're just picking out the relevant pieces for that day.
Yeah.
Because even, like, I do a lot of the stuff, I couldn't get through everything in a visit. Like, I would just pick out the few key things that are relevant based on why she's there and what her risks stand out as being most important. And then the rest can sort of disappear when you collapse it.
Yeah. And just in terms of case identification, then, is there a certain age group that you're targeting, or?
Anybody get pregnant in the next year.
Well, that could be any teenager too, right?
Yeah, so I think with the teenagers, my approach is always birth control unless they want to get pregnant. So this sort of, are you planning on getting pregnant the next year, would be a bit of a shocker for them, for most of them. So then it's just make sure you have birth control, and then you don't really go further on the form, aside from just doing regular care that you give them.
And this is both for male, female, or other, right? So,
yeah.
Okay. So in terms of logistics of when I would bring this up, because essentially you could bring this up with any adult then of childbearing age.
Yes. Yes, that's for sure. That's what we want to sort of target, is that this is relevant to so many patients.
So then we could put a reminder on Telus for that age group.
Yeah, I think the problem with that is I know my own EMR, we have so many reminders, you get sort of reminder fatigue.
Yeah.
Yeah.
Yeah. Okay. Yeah, I'm just wondering how often I would go to this. Like you said, there's so many other competing factors. And in your own practice, how many visits does it take to actually complete the whole tool?
I mean, I rarely do the entire thing. I really just target it. But I find it helps me identify things. So if there's one or two things that come up and then I see something else, I might say, you know what, at the next visit we should add this part or whatever. Or sometimes I just update their vaccines quickly, which makes a big difference in terms of either giving them prescriptions for what they need next time or just letting them know that they should consider certain things.
Okay.
I'm a little nervous about the time commitment, but
again, just think of it more as like doing part of it, not doing the whole thing. And the fact that it all collapses nicely is really helpful because it doesn't show all the empty parts. You can just scroll through and say, okay, I'm not going to touch nutrition, I'm not going to touch family history today, but today it seems like, seeing the links for smoking cessation would be really important because this person smokes too much for my comfort level. And then you can look through that link and do that.
This would be a perfect thing for when we used to do what we call physicals.
Yeah.
And now we're getting out of that. So it's I can see maybe when childbearing women are coming in for pap smears or renewal of birth control. That would, of course, those two times would be something that would click me into doing this.
Yeah.
It's just, if somebody's coming in for wart treatment and then we snap over to birth control, I don't know how much time I would have to.
Oh, for sure. Yeah, I think so. I agree with you.
Yeah.
So it's definitely choosing patients that you have that for. And I also find if there's some patients I don't see very often, even if they're coming for something small, I can just sort of quickly go through 2 or 3 questions, and then that's just an impetus for them to come back another time to further discuss things, as opposed to every couple of years when they come in for whatever.
I guess maybe once every 2 years you'll get a woman who comes specifically in just for this reason, right?
Yeah.
It's that thing where she says, I want to get pregnant, now what?
Yeah, exactly.
And I think previously I go, well, I guess I wouldn't be as in-depth as this tool would be, but that would be a perfect situation if, I think it's from leftover the years ago, like 50 years ago, men and women would come in for blood tests pre-pregnancy, right? For their, we got to know what our blood types are, and I think that's a leftover from those days.
Right. Yeah, no, very few come in, unless some of them I find if they're on certain medications, and I've told them in the past, like, if you're thinking of pregnancy, come on in. I sometimes get those patients, but yeah, most times people are not coming in for that, and we for sure recognize that, because otherwise you won't ever use this tool if you wait for that to come up from them. It's really us that's bringing it up.
Yep, yep.
And we do have the limitation, as you mentioned. We used to do annual health exams. We don't do that anymore. So, every 3 years is not enough to get some of this done, especially if we want to catch them.
And I guess most pregnancies are unplanned, right?
Yeah.
So, I mean, that screening question of whether you're going to want to conceive in the next year, you're going to miss a lot of those other pregnancies that are unplanned.
Yeah, for sure. And that's why, like, even saying things like for patients, like I gave the example of the thyroid, like we now know patients should up their dose as soon as they find out they're pregnant, but you want to tell them that before so they're aware. And some of the vaccines, let's say that if they need MMR or whatever, you want to make sure that they can't get that obviously when they're pregnant, so you want to make sure before that you've screened for rubella immunity.
Okay, well.
And this is once the tool is complete, it's complete. You don't revisit it, correct? Like if it's
you can, the same way these are chronic conditions that, mental health things, et cetera, you can for sure revisit it. And a lot of these things can't be managed right in one visit anyways. I mean, some of the stuff's easy, like update their tetanus and update whatever, but some of the more complicated stuff, especially with substance abuse, will come up again and again.
But you wouldn't necessarily open the tool to do that.
You don't have to, no. I mean, you can just identify it, or if you were looking back for resources, you can click on some of the links within the tool, because that'll take you to the websites that have the links.
How do we actually access the tool? Is it through custom form?
Yeah.
Okay, so under custom, you will be putting this into the custom form, and then, gotcha, okay, and then we just would be clicking on that.
I usually just write preconception, and then it pops up as an option, and I click it.
Okay.
Okay, sounds easy.
Oh, yeah, all right, famous words.
Stella's the positive one in this. She's a gung-ho.
That's great. We're going to...
yeah, I'm the draggy, blue bloating, balding skeptic.
That's good.
Yeah.
And Richard, that's the meeting that we come on December 11th to your site. That's where we're going to be doing that demo, bringing in EMR and kind of running through more the technical side of things and kind of answer any of the questions related to like the actual form use.
Yeah, yeah. Well, let's give it a go.
All right, sounds good.
And Christina, did you have any questions?
I'm okay right now. I think that I just need to go through it, like actually see it on my EMR, go through it, practice maybe using it, and then maybe I'll have more questions in terms of like usability and also like the feasibility of actually using it and time consuming and all that sort of stuff. So I feel like I just need to wait until I actually use it, and then I'll probably have more questions then.
Excellent. Okay. Well, look at us. We have given ourselves... Sorry, what was that?
Christina is another family doctor on here?
Yes.
Yes.
Oh, hi, Christina.
Hi.
The weather is very snowy in Guelph.
It's actually pretty snowy in Mississauga as well, too.
Okay.
As it looks like we've just given ourselves back a half hour, so go make good use of it. We have recorded the session, so I will distribute it around to everyone, so if you need to, you can refer back to it. And please feel free to email us if you have any questions. Like I said, we have set up meetings or site visits with both of your teams, so we will be seeing you in December.